Sir, we are live.
Right. Well, good morning, ladies and gentlemen. It's a great pleasure to welcome all the participants to this, the 20th edition of the ISG Masterclass. We have completed about 3 months of these sessions through on the ISG platform, and it's been very heartening to see the great response we have had from participants all over the country, from India, all the states, as well as from our neighboring countries. And overall about 28 countries have participants have participated in these sessions. Well, this morning we are missing Dr. Govind Makharia, Secretary General of the ISG, who is tied up with some personal issues related to COVID and won't be able to participate today. And it's a great pleasure to welcome Dr. Shalimar, who is the moderator for this session as well as the co-host. Shalimar is the additional professor of gastroenterology at the All India Institute of Medical Sciences. All of you know that he took a brilliant masterclass on autoimmune hepatitis a few weeks ago, and he is leading the hepatology, the liver diseases work now at the All India Institute, which is a pioneer in this area in the country, and is carrying on the tradition of stalwarts like Professor B.N. Tandon and Professor Subrat Acharya. Well, the topic for today's masterclass is acute on chronic liver failure. What is new in the pathogenesis and management? Many of you will remember that about a couple of months ago, 13th of May, I covered the same topic on ACLF and management aspects, talking about what were the current practices and also talking about things like etymology and terminologies. Well, today, to move on from diagnostic criteria and labels to what is the pressing problem in the field of ACLF, understanding pathogenesis of the condition, and developing treatments based on this pathogenesis, which will have an impact on this entity. We have none other than the pioneer in the field of acute and chronic liver failure, Professor Rajiv Jalan. Rajiv is the person credited with actually coining the term acute and chronic liver failure almost about 17, 18 years ago. And he has been the leader of the whole field of ACLF globally, as well as particularly pioneering this work in Europe. There is a long list of achievements and accolades that Dr. Rajiv Jalan has accumulated over the years. He is the professor of hepatology at the Institute of Liver and Digestive Health, University College of London Medical School in London. Also a consultant at the Royal Free Hospital, where he heads the liver failure group, and has been a past editor-in-chief of the Journal of Hepatology, the EASL Journal, just to name a few notable achievements. Presently, he is the European Union coordinator for exploring 2 projects that are exploring novel therapies for the treatment of liver failure. Apart from being a leading researcher with over 25 clinical trials to his credit, the huge number of 415 papers with H index of 89 and over 25,000 citations. He is also the scientific director of the Cliff Foundation that you know is heading the ACLF work in Europe. Interestingly, he has also founded a company called Yakrit, which is working on these liver failure devices, and he has invented the device called Dialive, which I'm sure we'll be hearing about in his talk today. And many of us know him as the person who is who developed the drug LOPA, ornithine phenyl acetate, for the management of hepatic encephalopathy. So this is just to name a few of his achievements. Now I'll request my co-host, Dr. Shalimar, to say a few words and invite Professor Jalan for his talk. Shalimar.
Thank you, sir. On behalf of Indian Society of Gastroenterology, I welcome Professor Jalan, who's our first international speaker, though He's an Indian, but still we consider him as the first international speaker to be part of this master class being done by the Indian Society of Gastroenterology. Professor Jalan is world-renowned expert on acute and chronic liver failure, as mentioned by Professor Saraswat, and his important publications on the pathogenesis and management have opened our eyes regarding what to look forward and how to plan regarding the future aspects of this disease. He's got lots of patents, and his work has led to a great insight in the pathogenesis and management. And his latest publication from the EASL consortium, for which he is the pioneer also, is the PREDICT study, which has led us to an interesting aspects of 3 different clinical phenotypes of acute decompensation. We look forward to your talk on the newer insights in the pathogenesis and management of acute and chronic liver failure. Over to Professor Jalan, please. Please share your screen and start your talk, sir.
Okay. Well, Shalimar, Vivek, and ISG, thank you for this very kind invitation. I'm really happy to be here. And I think that this new way of working is probably the way of the future. And I congratulate you on putting this together, because I think all of us in the West need to learn how to do this better rather than having to travel around the world to do this stuff. So when I was speaking with Professor Saraswat, who invited me to do this talk, I set the tone for this talk today based around how I see the next 10 years in terms of where ACLF will go, as opposed to working from where we have been in the last 10 or 15 years. And so therefore, it is a little bit backward looking, but is also very forward looking in terms of what we're going to do. So here are my conflicts, which are all real, because you'll hear something about some of these things in my talk, and I advise you to take this into consideration. So my passion is to find new treatments for liver failure, because our patients are not getting a good deal. Nearly more than 2 million people around the world are dying from liver failure each year. And this mortality has not changed for about 30, 40, 50 years. So I think it is our job now to start to make a difference to what we're going to treat these patients better, rather than to observe the story, which I think we've done a lot of, and we can move to the next stage. So this is what I'm going to do today. I'm going to talk a little bit about acute and chronic liver failure, the way I see it. And hopefully what you'll get from that talk is why I see it, why I think that putting a disease into context of measurable endpoints is crucial in the development of treatment. Because unless you know what you're studying, you will never ever, your disease is so heterogeneous that you'll never ever be able to develop a new treatment. And the second sort of element of my talk is really to simplify what is a very complex disease condition, and to break it down so that we can start to think about how we are going to develop therapies for this situation. And I may not go into a lot of detail, but hopefully you'll get a sense for the direction of travel to develop new therapies for this situation. So just to put the story into context, I think, we are all clinicians. I think more than 90% of people in the audience here are possibly clinicians. So this is a very common story. This is a patient with, David is a 52-year-old man who is a common presentation in my clinical service, young man, 52 years old, who drinks 2 large glasses of wine a day. And he was diagnosed with alcoholic cirrhosis following a routine health check. He has no known liver disease previously. And following a bereavement so he's been largely abstinent, but for 6 to 8 weeks, he goes on a bender following bereavement in his family. And this is what brings him to the hospital. He is admitted with jaundice. He has leukocytosis, ascites, and jaundice with a bilirubin of 9 milligrams per DL. And this patient was completely compensated before. And what has happened to him is come into the hospital now with a marked inflammatory response with what we call no ACLF. He's got an acutely decompensated cirrhosis. And this distinction is very crucial in terms of categorizing him as opposed to somebody else. But what happens to him over the next 4 days is he develops a rapidly progressive increase in his bilirubin up to 16. He develops grade 3 hepatic encephalopathy, has got some respiratory renal dysfunction, and is admitted to the ICU. And 5 days later, he dies from multi-organ failure, complicated by cerebral failure, renal failure, and liver failure. So his journey is very typical. That is a prolonged phase of decompensate or cirrhosis where we are not doing very much with him. A short phase of acute decompensation, which gave us about 5 days to intervene, but we did nothing for him. And then a very short period in the ICU when we probably missed the bus in terms of turning him around. And so it is really to put this patient into context, and this is what my passion is, to see in the future whether we can do something for him at each of these stages moving forward. And I hope you get a little bit of sense for what we may be doing. So as I said to you before, context is extremely important. That is, you have to describe the patient that you're studying. And I think about it in a simplistic terms about being a houseman on a ward, presenting my patient to my consultant. So here, what I'm saying is that this guy has got alcohol-related cirrhosis, which is his predisposing event. He's 52 years old. And as you'll see, both those events are likely to be important. His injury is likely to be acute alcoholic hepatitis on the background of alcoholic cirrhosis, which is the injury in his situation. His response is with systemic inflammation. So he's not coming with infection in this situation. He's got a marked systemic inflammatory response, which he's presenting with. And when he is entering the ICU, he's now got liver, kidney, and brain failure. So fundamentally, when you're presenting him on your ward round, you can talk about him as somebody who's got this syndrome where he's got alcoholic-related cirrhosis, alcoholic hepatitis. He's got marked inflammatory response without any evidence of infection, and he's got multiple organ dysfunction. So in a minute, what you're able to do is to categorize this patient into a box, which is what you can study in terms of developing drugs or whatever else you want to do in the future. So again, Professor Saraswat has already talked to you about this a few days ago, so I'm not going to go into much detail except to say that each of the words here are important. Remember that, what we are now getting to is a whole idea that an acute decompensation is a state which is completely different to a chronically decompensated state. So fundamentally, when you think about disease, liver cirrhosis, we've been told for the last 30, 40, 50 years, and this is a new paradigm, that either somebody has decompensated cirrhosis or somebody has compensated cirrhosis. I think that is an old concept. And what we need to insert is a new entity, which is going to be called acute on chronic liver dysfunction, or rather than acute decompensation, because that precipitation or precipitated event, which is bringing the patient into the hospital, is putting this patient into a different context, as opposed to that patient who is in the outpatient having had a history of previous decompensation. And that's not what I'm talking about today. But think about a patient who's hospitalized with acute decompensation, the high risk of death, and all these elements of multi-organ failure is the key to the story. And again, you've probably seen the slide before. Very simplistically, what we're talking about is that you can develop ACLF, or acute on chronic liver failure, based on any of these entities, producing slightly different syndromes. But once you reach cirrhosis, your short-term mortality is very similar. Whether you have compensated cirrhosis like David or decompensated cirrhosis before, it does not seem to matter. And I'll show you a little bit of data that when you develop multiple organ failure, your short-term mortality is exactly the same. The long-term mortality may be different depending upon the phenotypes that you are like before you start. But once you've developed multi-organ failure or organ failures, your mortality risk is the same. It doesn't matter. Noticed that we studied precipitating illnesses very carefully, and the two most important precipitating events are alcohol and sepsis. Nearly 90% patients who develop an acute decompensation will have either alcohol or infection as the two most precipitating events. And it's interesting that in about 30% patients, we do not find any precipitating event. And that has also been confirmed in the PREDICT study, which is what we found in the canonic study. All right, so I'm going to tell you a little bit more about this just to recap what I think Dr. Saraswat has probably told you before already. So these data are derived from the prospective study, which was done in Europe, so reflects a European perspective, but I suspect this has been validated across the world. And I'll show you in the next slide that in the US, in Europe, and in Asia, now this whole this concept is validated. And this talks to the diagnostic criteria here on the left, and I'm not going to labor the point again, that we are moving away from this whole idea that that liver failure is defined, or the outcomes of liver failure are defined by the severity of liver injury. And and if you can get around this whole idea that the mortality of a patient with cirrhosis who enters the hospital with an acute decompensation is contributed to by the failure of any organ system, as opposed to the liver itself, is what the most important change in paradigm is. That is whether, and you can see here on the right-hand side, that the diagnostic criteria for acute and chronic liver failure could be a single kidney organ failure without any liver failure. But in a non-kidney organ failure, you require a kidney dysfunction or brain dysfunction. For instance, in David's case, his bilirubin was only 9 at admission. He had no organ failures. So when he came into the hospital, by definition, he does not have acute on chronic liver failure, which he goes on to develop in the hospital. And what you can see here is that the mortality risk over 28 days, which is what we're trying to capture here, increases with the number of organ failures, with a very high rate of death in patients with 3 organ failures or more. So, what you've done now, what we have been able to do now is to put David into context. So when he comes into the hospital, he's got acutely decompensated cirrhosis. But when he has gone to the ICU, he's developed these 3 organ failures with an attendant risk of death of 68 to 88%, depending upon what his numbers are at that point. All right, so this is really important. So this, again, I think is a really important slide, because what it does on the left here is to validate this whole idea. The different dots here represent studies from around the world. It's not only European. There are studies from the US, there are studies from Europe, and there are studies from the US, Asia, and even the US. So it is not one study. In this particular slide, there are probably over 5,000, 6,000 patients. So there's nobody who needs to talk about validation here anymore. So A means on admission. As you can see, about 30% patients will have ACLF on admission. And like David, about 10% patients will develop ACLF after hospitalization, come in with decompensation, then goes on to develop decompensation. This is the mortality here. As you can see, 28-day mortality is about 35%, which is, again, what we know already. And here is a 90-day mortality, which is higher than the 28-day mortality, which is the first observation that the canonic study made. And here is the real validation of the story, because if you do not fulfill criteria for ACLF, your risk of death is extremely low. So fundamentally, what you've got is validation of the canonic study that the proposal for the diagnosis, a diagnostic criteria is correct. Now, why this is important is because of this slide on the right-hand side. You know, if you're able to categorize patients and not only to bucket them because of their prognosis, but also to bucket them because of the potential for reversibility. So if you're going to develop new drugs, new treatments, new interventions for patients with ACLF, you have to understand which bits, which patient populations you can make a difference to. Because if I took all the patients that came in here, as you can see, or all the patients with acute decompensation and ACLF, my mortality risk is 0% to 100%, depending upon the severity of ACLF. So what I need to do is to find a group where I can make a difference. And if you look at this slide here for a minute, so what you've got on the x-axis here is patients in different ACLF grades, okay? And on the y-axis is about the percent of patients at the last assessment. So of all the patients that came in with ACLF, nearly 55% patients will develop no ACLF, and the risk of death is like that of patients with no ACLF. And that's really, really important to understand, that there is reversibility, there's a potential for reversibility of ACLF, which reduces progressively as you go from ACLF 1 to 2 to 3, which means that only 16% of patients who've got ACLF 3 have a potential for reversibility with our current approaches to therapy. And therefore, we need to think about how we're going to manage these patients differently to those of ACLF 1. These are very simple, practical questions that you need to answer at the bedside in order to decide what is the best treatment for my patient and what are you going to tell the family about what is likely to happen to your patient in the future. So the important thing to take away from this right-hand side of the slide is exactly this, that there is a progressive reduction in the risk of reversibility. And, you know, you can put this into another way. You can think about this as a regeneration potential. That is, the more severe the ACLF, the less chance of regeneration there is. You know, and that is a little bit of a leap of faith, but I'll come back to this towards the end of my talk, because that is a key differentiation, a key thing to understand if you're going to develop new therapies. A couple of words about clinical characteristics. Like I said before, these are data from Europe. So what you'll see is that there's an overrepresentation of alcohol, but I now know from Dr. Shalimar's work that India is no different. India, the predominant number of patients that you're seeing with acute decompensation and ACLF are probably on the background of alcohol. Also, this is really important, that there is no difference between patients with and without prior decompensation in terms of determining the risk of developing ACLF. And I'm not talking about outcomes here, but prior decompensation or the lack of prior decompensation or its presence doesn't define recoverability, because that seems to be independent of whether or not you've had previous episode of decompensation. And I don't have a slide here for this particular talk, but it seems that those patients that have got prior decompensation may in fact have a lower risk of death from those that are presenting for the first time. So a very important concept that your overall outcome is not different over a short period, although long-term outcomes may well be different if you're prior decompensation. This is very important. The second point to note here, and this is again absolutely crucial, if you're going to develop new treatments. These are looking at precipitating events. And as I said before, that about 30 to 40% patients we cannot find a precipitating event. And now we're going to start calling them indeterminate precipitating events, but that is a discussion which is ongoing. But as you can see here, bacterial infection is the most important precipitating event for the patients that we deal with. And this has now been confirmed in the PREDICT study, where we set it up to look at the precipitating events carefully. As you can see, as you move from no ACLF to ACLF3, bacterial infection underlies the risk of development of ACLF to up to 41%, which is massive. And the second most important precipitating event, certainly in the UK, in Europe, in the US, is active alcoholism. So we now think about calling them bona fide precipitating events, with all the other precipitating events is being peripheral. What is also really interesting is that if you look at GI bleeding, which if I were presenting this slide to you 10 years ago, not 10, 20, 25, 30 years ago, GI bleeding would have been a very important precipitating event for the development of ACLF. But now, less than 3, 4, 5% patients have GI bleeding as a cause of acute decompensation. There are plenty, but of development of ACLF is relatively small. So it's really interesting because we are much better at managing these patients. And the phenotype may be slightly different in India and Asia, but certainly in Europe and the US, this is what we see. So important question, therefore, is what about the pathophysiology of this situation? I'm going to talk a little bit about it in a little bit more detail as we move forward. But simple things are simple, you know what I mean? It's a simple syndrome. You can look at these patients at the end of the bed, like David, and what you see is that systemic inflammatory response is probably the most important differentiation pathophysiologically. It is an ultimate manifestation of what has happened to David over a period of time. So this is the first observation that we made, very simple, end of the bed test, higher white cell count and higher CRP in patients with ACLF compared with those without ACLF. These numbers here represent the values, higher values. And this is represented in the kind of cytokainemia. If you look at TNF-alpha, is higher in ACLF patients, IL-8 higher. So the point is, it's very simple, that there is a very clear distinction in terms of the inflammatory response. But of course, for those of you who study inflammation, etc., you know that the manifestation of what you measure here is an accumulation of multiple causes of how you've got here. And that is what is the key to understanding how we're going to treat these patients better. So if you think about going from injury to systemic inflammation, and then there is the occurrence of organ failure. But in the middle, there's a lot of things going on. And I'll just show you that in the next slides. But before I do that, to just take you through one more step in terms of prognosis, because if you're going to be doing clinical trials in this patient population to develop new therapies, you have to understand that you have to categorize these patients a little bit better. So what about prognosis? Can I make a prognosis? Because remember that the larger the standard deviation in the risk of death that you predict, the larger the number of size, larger sample size you'll need in order to detect a difference. So what we are always doing as clinical trialists is trying to find a group of patients that are likely to have as low a standard deviation for your endpoint as is possible. And conceptually, that's very important. And therefore, what we went on to do was to define a scoring system. It's called the CLIF-C-ACLF score, which is based on measurement of the CLIF organ failure score, age, and white cell count. We combined them into mathematics, and we validated it. And there are 2 points that I want to make on this slide, which contains a lot of information. The first is that this is the first set of data. As you can see, a C index is really defining the predicted versus observed risk of death. And as you can see here, that this scoring system performs significantly better than MELD and MELD sodium. It is important to understand that this is not by chance, but it's by definition. If you've shown that the risk of death is related to organ failures other than the liver and the kidney, such as respiration or circulation or brain, which are not captured by the MELD score. So therefore, it's just another form of validation that the outcome of our patients with ACLF is different, has to be different. The markers has to be different. And that just validates it. The second point to make is here on the bottom slide. Okay, this is absolutely crucial because a lot of commentators have suggested that, the CLIF ACLF score is not very accurate, but it's only 75% accurate. But remember that a lot of times we're seeing patients 3, 4, 5, 7 days after they have presented to another hospital or deteriorated. And as you can see, the performance of the score improves with time. The way you use the scoring system is to use it on a daily basis to update the prognosis of your patients that you're seeing in front of you. 75% accuracy when they come into the hospital to nearly 86% accuracy if you're using that score at day 7. So, which is, again, all the scores improve. Here you can see the MELD score improves as well. But the point is that it does not improve as much as the CLIF ACLF score. And finally, just to show you Chairman's data, this is data produced by Dr. Shalimar, which validates the CLIF ACLF score as the best performing score in a patient population with severe acute alcoholic hepatitis in the community. And it's very, very nice to see that a score developed in Europe is validated in a slightly different population in India, predicting the risk of in-hospital mortality, 90-day mortality, and 1-year mortality. And he compares this with all the other scores, that there are very clear distinction that the CLIF ACLF score can be used effectively in India to define the outcomes. But today is not a talk about outcomes. It is more of a talk about treatments. So if you turn this clock around and you say, why? How am I going to, why am I telling you this? I'm telling you this because I need you to understand that if you're going to treat patients, I've got to use a scoring system which I can use and update and has validation that allows you as a user of a drug that I develop to be able to put your patient into context to find out as to whether your patient is likely to respond or not likely to respond. And that is the sort of the mindset that you've got to get to when you read clinical trials. If you plot it, this is what you see, that ACLF is a heterogeneous entity. On the y-axis is estimated probability of death. On the bottom axis here is the CLIF ACLF score. What you see is it's a sigmoid curve, which means that at the top and the bottom end, here, as you can see, a score above 65 or 70, it's a risk of death of these patients is nearly 70, 80, 90%, 100%. If you have patients here at the bottom, up to a score of 30, and you include them in your clinical trials, and you want to look at survival, then you will not get a right answer because the mortality risk is so low. These patients up here are too complex and probably not for new trials. And if you look in the right here, therefore, a patient with a CLIF ACLF score of less than 34 is very low risk of dying, so you don't want them in clinical trials, which is looking at survival. A CLIF ACLF score, we think between 35 at this point here is probably perfect because you can make a difference to them. And we think that these patients down here are too sick. So very important. And I'm going to spend a little bit of time on this slide here, which we think is a modern view of the pathogenesis of ACLF. I don't have time to show you all the data that this is built around, but I'll come to this in the next slides in a little bit. So we at Cliff, and this paper was published last year in the Journal of Hepatology, and well, these are data which were presented for the first time in the New England Journal review that we just wrote, but it was presented, the base of this hypothesis lies in the paper, blood metabolomics paper that we published in the Journal of Hepatology a few months ago. So just to take the left, panel A is what I want you to focus on. The right is probably more detailed, which we're not going to talk about today. This is the sort of the interpretation of nearly, 10 years of work in this one panel here. What we think is going on is that there is two things that are occurring. One is there's bacterial translocation and pathogen-associated molecular patterns, which in our patient, David, was a bacterial infection, okay, which sets up a systemic inflammatory response, which is manifested by cytokine-mediated activation of the hypothalamic pituitary adrenal axis. And this is what we observed clinically in our metabolomic study. What we observed was there is serious increase in glycogenolysis. There's very marked lipolysis. There's serious proteolysis. And these are done to fuel, we think, inflammatory reactions. And there are two things that can happen from here with nutritional therapies or other if you're managing stuff upstream of that, you might get regression of systemic inflammation and the patient resolves. But if this does not resolve, there's a further progression of systemic inflammation, which can lead to immune-mediated tissue damage. So if you look at the organs, you see evidence of injury. You can see that there is, in the kidneys, there is tubular cell death. In the brain, there's activation of microglia. The lungs are not right, etc. This is a second hypothesis, which we think are probably interrelated, where the mitochondrial oxidative phosphorylation starts to shut down. There's mitochondrial dysfunction leading to multi-organ failure. And at this point, I think the patient has gotten to the state that I described to you in my clinical course of the disease, that the chances of recovery without doing something dramatic is very little. And these are patients we think with, grade 4 to 6 organ failure, where they have got to a point where they've got a mitochondrial shutdown and the chances of survival would be very little. And these are sort of just to illustrate that this is not purely hypothetical from the basis of, from made up story, but it's based around a very detailed blood metabolomic study, which starts to indicate that these processes here biologically are probably correct. Whether it's a consequence, whether it's an association, or whether it follows on is a matter of conjecture at the moment and will require many, many, many new studies to start to unravel. So a modern view of pathogenesis takes into account immunometabolism, immunopathology, which is consequent upon systemic inflammation, which stems from DAMPs and PAMPs as targets of therapy. So the whole story started by injury, translocation, infection, and the rest of the stuff is happening downstream. Okay, very important concept. But if you have that as a hypothetical view of pathogenesis, I don't think that you can actually treat a patient very well. It's far too complex. And what I did here is to simplify it, which starts to develop possible therapeutic targets that is within our realm in order to do something. So simplistically put, we think it's here, liver injury, chronic alcohol consumption, bacterial translocation leading to cirrhosis. What cirrhosis does is to sensitize extrahepatic organs in the immune system. Because remember that the patient has developed multi-organ failure. So how can it happen all of a sudden? That is, a patient gets a second hit, insult in our case was alcoholic hepatitis or bacterial infection, and then everything, all the organs fail. So we think there's sensitization and priming of these organs, and we'll talk about potential mechanisms. These three things are key here. There's liver cell death, which are called damage-associated molecular patterns. There's bacterial translocation and metabolic failure, which I've introduced a term based upon our recent data. They're sensitized organs, so therefore they're susceptible. There's immune dysfunction, so there's susceptibility to infection, which sets up multi-organ immunopathology, systemic inflammation, and a risk of infection, which is what culminates, we think, in acute and chronic liver failure. And it's the severity of this syndrome that will define what it is, the recoverability of this is. I'll stop there, Professor Saraswat, to take any questions that there might be before moving on to the therapeutic section.
Right, Shalimar?
Yeah, I think we had a very exciting talk so far by Professor Jalan regarding the initial concepts on acute and chronic liver failure and pathogenesis. We've got lots of questions, so let's start the ball rolling. The first question is by Professor Siva Prasad from Visakhapatnam, and Dr. Santosh from Vellore have almost similar question. Is like, in the index patient which you presented and you based your talk on, how do you differentiate severe alcoholic hepatitis from acute and chronic liver failure?
So, and this is it's really, really important to understand the context we're talking about. Severe alcoholic hepatitis is a cause. So alcoholic hepatitis is not a different, it is a different clinical entity. Like hepatitis B is a hepatitis B associated cirrhosis with associated reactivation can lead to acute and chronic liver failure, but that's in the context of HBV. Here it's in the context of alcoholic liver disease. It's the same if you've got alcoholic liver disease with superimposed infection can lead to acute and chronic liver failure. When they reach this point of multiple organ dysfunction, we don't think that the underlying etiology of how you got there matters. Of course, your treatment paradigms may be different. If you've got hepatitis B, you'll give them tenofovir or entecavir or something else. But if you got alcoholic hepatitis and you had a new drug, you'd use that. But once you reach acute and chronic liver failure, your prognosis and your pathophysiology is dictated by the disease entity, by the failure of organs as opposed to the underlying etiology.
Okay, we've got a couple of questions which are almost similar. So Nikhilesh from Hyderabad has raised a question: is sepsis really a cause or effect of acute and chronic liver failure?
So look, I think, there is this confusion which, has been created by the apostle definition as opposed to what the rest of the world thinks. There is no doubt, you can quote this anywhere you want, that bacterial infection is one of the most important precipitating events for the occurrence of ACLF as it is viewed today. And of course, there is increased risk of new infection in patients with ACLF. There's no doubt at all. People who argue that it's a consequence have published exactly the opposite data in the recent global study, which was published from India and other places, where they show that infection is associated as a precipitating event with the occurrence of ACLF. So in my book, there is no doubt that bacterial infection is a key, not whether or not, it's a key precipitating event for ACLF.
Okay, Nipun from PGI Chandigarh has asked, how do you differentiate sterile inflammation from sepsis in acute and chronic liver failure?
That's a really, really good question. Remember, I'll show you in the next slides that these patients have got a large amount of liver cell death going on. And what they have is immunogenic forms of cell death, which is through apoptosis and necroptosis, which can set up a sterile inflammation. And at this point in time, the only way you distinguish is by doing cultures, and cultures, because we have got no other good way of defining the difference.
Okay, Prajna Andavaram from Cuttack has raised a question is like, which you talked about also, is like, do we know that there are right now differences in the metabolic signatures between AD and chronic liver disease and acute and chronic liver failure patients? And do they really translate into clinical practice right now? And what do we expect from them?
Again, this is a terrific question. So we are just starting to walk this new road. We are not reached there yet. The first study was published by Mark McPhail from King's, who identified a sort of a signature, which was added to by the recent canonic study that you might have seen in Journal of Hepatology, where we now have a fingerprint of 5 metabolites that you can measure in order to determine the potential outcome of your patients. If that has not been validated yet, we're going to validate it in the PREDICT study, so hopefully that should take this forward. But you see, the reason for studying these is not necessarily just for diagnosis and prognosis, but is to try and understand as to whether you can alter the course with certain interventions, which may be nutritional interventions, which may be interventions related to modifying mitochondrial function, modifying inflammation, and so on. So this is really what I said. It's a new concept. That's what it's about. So it is about immunometabolism, organ pathology, and how you might be able to impact on those with better understanding. So not just a fingerprint, they're potentially therapeutic targets.
Okay, thank you, Professor Jalan. Let's move forward to your next part of the talk.
Okay, so let me stay with this slide for a second, because that's what I'm going to base my drug development on. So what can we do with this whole idea that David is now in the hospital with an acute episode of decompensation? Is there something that we can think about in this situation? So one of the things that, we talked about pathogen-associated molecular patterns, and we will talk about damage-associated molecular patterns in a minute, which are driving, we think, systemic inflammation. There's a lot of evidence, and these are data from Ramon Battaglia, which is in patients with acute alcoholic hepatitis with ACLF, or just with acute alcoholic hepatitis. And what he was able to show is that LPS is important in determining the outcome of these patients. And as you can see here, this is a slide that I've already shown you. Bacterial infection is very important. So we were sort of simplistic clinicians, and we're thinking, so what is it about these that are important? And what you know is that the toll-like receptor 4 is the receptor that is targeted by LPS or gram-negative bacteria. And when TLR4 is targeted, then it sets up a train of inflammatory response, which ends up in cell death, which may be necrotic forms of cell death. So simplistically, we said, okay, so if that is a situation, what can we do with these? Can we do something about LPS? Can we do something with TLR4? So this is the first study that we published recently, where we are working with something called recombinant alkaline phosphatase. So alkaline phosphatase, as we know, is produced in the biliary system and is a very important liver cell marker. But what its real job in the body is to dephosphorylate LPS, which means that it cleaves off lipopolysaccharides, and it prevents its action in terms of what it can do. So this is a study that we published recently. And what we did here was to make a model of cirrhosis, which you'll hear about a lot in the next slides. And if you hit them with LPS, you can create a model which looks like ACLF. And these animals die from multi-organ failure. And that's what we're trying to recapitulate here. And we treated them with recombinant LPS, alkaline phosphatase, before and sacrificed them. What you can see here was very interesting is your groups of animals here. The sham animal treated with alkaline phosphatase, sham animal treated with LPS, and you're measuring LPS levels here. What you can see is this is an animal treated with alkaline phosphatase and then with LPS. And here are my bile duct ligated groups treated with alkaline phosphatase. The first thing to see here is that their endotoxin levels in the animals that we administer LPS is very, very high. But if you measure the activity, you can see that those that are administered alkaline phosphatase, LPS is very high, but if you measure the activity in those that are treated with LPS is much lower. So this is what we see here, and we're measuring ALT. What you see is there's a bile duct ligand group here, that's the sham LPS. If you are giving alkaline phosphatase to those treated with LPS, there's a significantly less increase in bilirubin. So here is the bile duct ligated plus LPS, very high ALT levels. But if you treat them with alkaline phosphatase before, there's a very marked reduction. This again provides a proof of, and here's a tunnel stain, which essentially defines cell death. If you're treating these animals with recombinant alkaline phosphatase plus LPS, more brown represents more death. As you can see, very significant serious death here, very markedly reduced cell death. What it taught us was that LPS is important, and taking it out or deactivating it may be a therapeutic target. And as you know, this is being developed for treatment of acute kidney injury at the moment, and hopefully we can repurpose it for our studies. But our interest was really to validate this next study, which was to ask as to whether or not we can target toll-like receptor 4, which is a ligand, which is a receptor for LPS. So we went and took a large number of patients, and we measured either the LPS concentration, we measured products of cell death, which is with nucleosomes. And here what we did was to take a toll-like receptor 4 cell line and incubated a patient plasma from decompensated cirrhosis. What we saw was that there's a high concentration of LPS, as Ramon had found, in those with severe decompensated cirrhosis. The nucleosomes, which represent products of cell death, were very markedly elevated. If you incubated the plasma with a TLR4 reporter cell line, there was a very marked increase. The second critical observation was that if I took samples of the liver from patients with ACLF, what we found was a very marked upregulation of the TLR4 receptor. So, and remember that the TLR4 receptor is essentially in immune cells. But here what we were finding was that this receptor is upregulated in the epithelial cells, which is in the hepatocytes, which meant there's epithelialization of the toll-like receptor 4. And now if you turn back your story to David, what's happened to him over a period of years, and that's a concept of sensitization. What's happened to him over years and years and years of cirrhosis is that he's upregulated TLR4 receptor, not in the liver, but also in the kidney and the brain. I'm not showing the data from the kidneys here, but we published that nearly 7, 8, 9 years ago. there's an upregulated TLR4 in the renal tubular cells in cirrhosis. So what you've set up is a really nice model where there's an upregulated TLR4. The ligands for this receptor is increased in the system, all right? And then we're looking for a inhibitor of toll-like receptor 4. And here we found something called TAC242, which was developed by Takeda for the treatment of sepsis, and it failed. And what it shows you here is, typical drug development slide. That is, if you treat with increasing concentrations of TAC242, a cell line, a monocyte cell line, incubated with LPS, there's no production of TNF. All right, and this is an in vivo situation where you administer these animals TAC242 after giving them LPS, the TNF production is progressively reduced. So it's a fantastic drug which can inhibit TLR4 selectively. It does not act on 2, 3, and 9. And so we took this to our animal model, which I've described to you before, and same setup, but here we either treated them with TAC242 before or after induction of ACLF, and the results were pretty striking. What you have here is % coma-free survival. Here's the bile duct ligated animal. If you give them LPS, almost all of them die in coma within 6 hours. If you treat them with TAC242 before hitting them with LPS, all of them survive, 100% survival. And if you treat them afterwards when they've developed ACLF with this drug, you can reduce the death rates to 50%. So here we now have a potential drug. We showed it to the FDA. The FDA has given us an orphan designation for this drug, and we're going to take it forward. And this is just a little bit more detail to that story where we show a reduction in cell death. And as you can see here, here is the bile duct ligated plus vehicle. We're looking at TLR4 receptor expression. If you treat them with TAC242, you reduce the amount of brown, which is interesting. Here is what we're showing is the tunnel stain. If you have bile duct ligate plus LPS, there's a lot of brown. If you treat them with TAC242, there's no more brown. And there's a tunnel which represents cell death. BDL plus LPS, a very high amount of brown, which is significantly reduced. But look, it's interesting that there's not only in the liver, but the same thing is going on in the kidneys here. That you've got apoptotic areas in the kidney is significantly reduced, but much higher in the bile duct ligated animal compared with the controls. So not only the liver, but also the kidneys are expressing this receptor, and which can be reduced significantly by treating them with TAC242. But just to put this into context, the study has just started in Europe, where what we're doing is to randomize patients with TAC242 versus placebo. Hopefully, we'll have the answer at the end of next year. And the primary endpoint, as you can see here, is CLIF-C ACLF score. We're including patients with grade 1 or grade 2 ACLF. And it is now converting clinical description pathobiology into a clinical trial, which, as I said, will be starting very soon. The primary endpoint is a change in the CLIF-C ACLF score. Okay, so what about liver cell death? And I'll just show you a couple of slides to indicate how this works. So the first thing to note here is, really the most important thing to note here is that CK18 represents an apoptotic form of cell death. K18 is a necrotic form of cell death. CK18 to K18 ratio defines the proportion of the main type of cell death. So if it's greater than 1, then it tells you it's non-apoptotic forms of cell death. Whereas if it is less than 1, it tells you it's predominantly apoptotic forms of cell death. I just want you to focus here, down here. What you can see is that if there's no ACLF, most of the cell death is apoptotic because CK18 related cell death is much higher. But when patients develop ACLF, you change to a necrotic forms of cell death. And why is this important is really illustrated in the next two slides. Before we started with thinking about targeting inflammation, this is the first study, I think, ever that we did in ACLF patients, where we used emricasan, which is a drug which inhibits apoptosis, and we really had no effect whatsoever. So pathophysiology is more important than going directly to a clinical trial. So this trial preceded the last slide that I showed you. So anti-apoptosis drugs does not work. What you need to do is a little bit more. And why this does not work was illustrated in the previous slide, which is the form of cell death is mainly non-apoptotic. What does that mean in practice? This is what it means. So here is apoptotic cell death, which means that it is a very controlled form of cell death. These two are regulated forms of cell death called necroptosis and pyroptosis. And just to sort of give you a little headline here, this is a RIPK1 dependent cell death, which is an enzyme that triggers MLKL, and it makes little holes in the cells. Pyroptosis is another newly defined form of cell death where the cells actually just burst. And this is a caspase-1 dependent form of cell death, which is very important. Why this is important is because as you move from apoptosis to non-apoptotic forms of cell death, the form of cell death is more immunogenic, which means that these damage-associated molecular patterns lead to much more severe inflammation and the risk of death. All right. So what is the evidence that anything is going on here? And again, what we did is to go to our patients first to see as to whether this is exactly what you see here. And what we are measuring here is RIPK3 in the plasma. This is RIPK3 is, as you can see in this slide, downstream of RIP1 activation. So it represents, it's a biomarker for necrotic cell death. Now what you see here is that as you move across the grades of ACLF, there's higher amount of RIP3. Acutely decompensated patients have a very marked increase in RIP3. And that is something that we can reproduce in the liver. That is, we can find increased RIP3 staining. And as you can see here, phospho-MLKL, which is the final arbiter of necroptotic cell death, which is going up and making holes in the cell, very significantly increased in immunohistochemistry in the liver. So good evidence that necroptotic cell death is important. So what about targeting it? And so there are drugs that don't have too much time. I think I'm running out of time, but what we did is to use necrostatin, which is essentially an inhibitor of RIPK1. And what you see here is that there is a significantly reduced amount of injury in the liver. And we went on to show that the kidney is also protected. NEC1 is a dirty drug. We've now reproduced this same study with RIPA56, which is a very specific inhibitor of RIPK1 and therefore a potential therapy. And these are just showing you high-level stuff. And we have not yet gone into clinical trials with it, but we're thinking of it. This is a second important form of cell death, the work done by Dr. Mehta in my group, who sort of is leading this whole piece of work. So what he showed is that LPS can either signal through the TLR4 system, which I've already described to you, but LPS can also enter the cells and work through a separate system, which is called the non-canonical inflammasome. And what it does here is to form this substance called gasdermin D, which is cleaved and leads to the release of these DAMPs, such as IL-1, but also makes holes in the cell, just bursts the cells. And he went on to show that in patients with ACLF, there's very significantly increased amount. These are patients with liver disease, high amounts of gasdermin D in the liver, which suggests that these non-apoptotic forms of cell death are also activated here. And he went on to show that if you take out caspase 11, which is a key regulator of this. In his animal model here using carbon tetrachloride, there's a very significant reduction of this. And he is now working with repurposing some drugs that targets caspase 11 and can reduce spiroptosis. And that's a trial. Hopefully you'll see coming through very soon, because we can go directly to a phase 2 study because we are using repurposed molecules that inhibits caspase 11. What about multi-organ immunopathology? So this is what I've been passionate about for a long, long, long time. And if you've followed my story so far, what we're talking about is DAMPs and PAMPs accumulation in patients with ACLF. So this is a device that we developed nearly 10 years ago, 7, 8 years ago. It's called Diagnostic. It essentially incorporates 2 filters. So what we did is to repurpose Prismaflex, which is a kidney dialysis machine. And as you can see here, we use 2 filters. One is an open filter, which is about 60 kilodaltons. And I'll come back to tell you why we have done that. And the second filter is an adsorbent, which takes out genomic DNA, nucleosomes, HMGB1, takes out LPS. And we use these in context, so they're together, they're clamped together. And the first membrane is open membrane, which does, in addition to taking out DAMPs and PAMPs, also ultrafilters albumin. As you know, albumin is completely destroyed in liver failure, and the accumulation of the bad albumin is immunogenic. So therefore, that can elicit an immune response by itself. So the first membrane is an open membrane, takes out the damaged albumin, and also takes out cytokines. The second one takes out DAMPs and PAMPs. And this study showed in our animal model of acute liver failure here a very marked improvement in survival, which is what has taken us to this study, which I'm happy to say has just finished. And hopefully you'll be seeing the data very soon. So we're in the process. The database lock is probably next week. So we'll be having the data for this very soon. But again, what we're building on here is understanding of the pathobiology, understanding of the clinical syndrome. We included patients with ACLF 1 to 3 in this, CLIF ACLF scores of 35 to 64. And of course, safety was the endpoint. What we've done is randomized 30 patients to receiving Dialab or standard of care. We've given them 3 to 5 sessions. The primary endpoint is at day 10, because at that which we think CLIF ACLF score is reflects as a surrogate for mortality later on. And I can tell you the device is safe. We think it does something, but I know nothing more because the data is in a locked database as we speak. So really interesting, but building on the pathobiology, DAMPs and PAMPs removal, exchanging albumin, which is not something that I've talked about today. What about GCSF? This is obviously the pet drug which came out from India. And, it's interesting that there are 2 studies here which are exactly the opposite. The first is from Professor Sarin's group, which I think was really, really exciting to see that patients administered GCSF in ACLF patients using the PASL criteria had a significantly lower mortality compared with those treated with ACLF. And sadly, this study could not be reproduced in a very large study in Germany, where the study was closed early for futility, but also because there was possibly a higher mortality in the group treated with GCSF compared with the placebo group, as you can see here. Of course, not significant. The study was closed early because of futility. So very different, and we can discuss why this is the case. So for the last 2 or 3 years, we've been interested in trying to understand why is it that there is such a difference. And we go back to animal models. And I'll show you some data which is not published yet, but I think that it is a very, very interesting and possibly helps you develop a new approach. And I just wanted to focus on this slide here. We're looking at mortality of these mice who got carbon tetrachloride-related cirrhosis. Here is a vehicle. That's the animal with CCL4. We hit these animals with LPS. Over 48 hours, over 5 days, their mortality is 0%. If I treat them with GCSF, the mortality is very high, at 66%, exactly the opposite of what you observed in the Indian study. And this is very interesting. So we are increasing the mortality of these animals with ACLF when you gave them GCSF. And we have gone on to look to see why. It looks as if there is a further increase in the inflammatory response in these animals. But of course, if you play this out, it is not surprising, because what you know is what GCSF is doing is that in addition to releasing bone marrow-derived stem cells, it also leads to a release of large amounts of immature neutrophils and inflammatory cells from the bone marrow, where you can get white cell counts up to 20, 30, which are entering into plasma, which is dirty. Because I showed you before that if I take plasma from cirrhotic patients or ACLF patients, incubate them with immune cells, it activates them. And that was a slide that I showed you during the TLR4 discussion. So it is not surprising that there is a worsening of the inflammatory response, which may be responsible for this death, which is really, really important. We also saw that even in 5 days, their fibrosis was worse, and we don't quite understand that mechanism yet. So we've now been trying to figure out, how do we enhance the effect of GCSF, make it safe? If you work from the hypothesis that why these animals have a higher mortality is because of the release of these inflammatory cells, which are TLR4 bearing cells, can inhibition of TAC2, using TAC242, improve the effect of GCSF? And that's what we see here. That is, we're looking at cyclin A on the bottom here. You can see very little regeneration when you give them LPS. But if you treat them with TAC242 and GCSF, you can increase the amount of regeneration in the liver. This is looking at a percentage, in percentage terms, something to give you quantitative sense, very marked increase in regeneration compared with those that are treated with TAC242 alone. And if you look at liver injury using tunnel, it is very markedly reduced risk of injury while you're improving regeneration. So there is an inhibitor of regeneration, which is in the liver, which we think is inflammation. And so we are now proposing to do a study using a combination of TAC242 and GCSF, hopefully in the next, so we've got a grant with the EU. So if you get that, then we'll start that study. I just want to finish with this, because if you take home one message today, you should take home the message that you have a curative treatment for ACLF. In the most severe patients for ACLF, who have got, in David's case, when he reaches at this point, using the CLIF ACLF score, his risk of death in 28 days is 78%. If you got ACLF3, think about a transplant. So in the absence of ACLF, the mortality risk following a transplant, there's a large database, and this is the work done by Vinay Sundaram from Cedars-Sinai in Los Angeles, who we've been collaborating together now for 5 years or so. I think it's pretty dramatic data where he shows that the risk of death following a liver transplant of no ACLF patients is no different to ACLF 1 and 2. And here is the patient with ACLF3, who have only a 20-25% risk of death at a year, compared with universal death, large numbers of patients. And this data has been validated by multiple groups since. The second point to make, don't have time to go into too many explanations here, but the MELD score is no good for allocating organs for patients with ACLF. And I'll just illustrate to you this graph here. In ACLF3 patients, you can see here that there are about 40%, 45% patients who die who've got MELD score less than 25. So these patients will not have any priority for transplantation, certainly in the UK or in the US or in Europe, because the organs are being allocated based on the MELD score. Large numbers of patients are dying with low MELD scores. So think about a liver transplant. Now, what is interesting here, when you look at a sort of a multivariate analysis, is that the things that define the risk of death are if you have to wait too long on the waiting list, when you're using terrible organs with a DRI index which is very high, and in mechanically ventilated patients. We did not find any independence or prediction of risk of death in those with 4 or more organ failures or circulatory failure. So there is a degree of organ specificity. Lung failure is bad, but the rest of it you can transplant through. But even in those with lung failure, the post-transplant survival can reach up to 65, 70%. But of course, those patients do a little bit worse than the others. This is my summary slide, just to say thank you very much for listening to me. But we think ACLF is clinically, prognostically, and pathophysiologically distinct. And the reason for adopting a universal classification is absolutely key if you're going to develop new treatments for this syndrome. Infection and acute alcoholic hepatitis are the commonest etiology of ACLF in the West. In China, we think it could be reactivation of hepatitis B as a third bona fide, very important precipitant. The pathophysiologic basis really starts to provide new therapeutic approaches. And liver transplantation is the key really for the sickest patients in whom drug therapy at the moment is unlikely to save their lives. So think about a transplant, but hopefully in the next 5 years, what I'm telling you with respect to early phase development of products will reach patients. Well, that's a hope, if any of these things work. And again, the many people who have provided me with inspiration to continue, and I need to thank them. CLIF is a central organization which has sort of collaborated with us over a long time, and the EU has been very supportive in terms of grants, in terms of where we are today. So I'll end with that and hand over back to you, Shalimar, and to Professor Saraswat.
Right. Thank you very much, Rajiv. Thank you very much, Rajiv. And
thank you.
A lot of new information and insights have come in. Maybe if you could please stop sharing your screen, we'll come to the gallery view and we'll try and cover a very large number of questions that have come your way from the audience today. So to begin with, I think I'll just go back to the early part of your talk. There is this question from Dr. Shiva Prasad from Visakhapatnam, who wants to know that the entities of ACLF, no ACLF and ACLF 1, 2, and 3, do you regard them as separate entities, or they should essentially be looked at prognostic scoring systems for severity of liver failure, perceptually?
Okay. So fundamentally, it's about people that lump and people that divide. So I think that, as a simple hepatologist, it's much easier to put things into buckets because we can see it clearly. And, so to me, I think we should be very clear about a patient population that's got a low risk of death versus a population that has got a high risk of death. Patients have got a pathophysiology which is significantly different as you transition from no organ failure to organ failure, because that is the knowledge that we have at the moment. So I would very clearly define a group that is, so we think that acute on chronic liver dysfunction is completely different to stably decompensated cirrhosis. And within that, there are two syndromes. One is that becomes apparent once organs start to fail, which is what we call acute on chronic liver failure. And although we are not proposing it, but hopefully we'll develop a new terminology where we will have a group which is called acute on chronic liver dysfunction, which falls short of acute on chronic liver failure. So I'm a divider because I'm simple, I think simply, rather than carrying this whole burden altogether.
Okay, right. Similarly, Dr. SG from Chennai as well as Shiva wanted to know whether the CLIF-C ACLF scoring system you apply to your population. Recently, the APASL group, the ARC group, has defined their ARC criteria also. So have you applied that to your population of patients, and what are your observations in that regard with their prognostic scoring system?
Yeah. I think the problem that I have is that when you pre-select patients based upon lack of infection, only including compensated patients, compensated liver disease patients, you change completely the model that you're testing. So if you've predefined an entity where you have excluded the largest proportion of patients that we see in clinical practice, though that scoring system, to me, this is my personal view, is not very useful in clinical practice. So fundamentally, we can only do the best that we can do. And, you should apply the CLIF scores to your programs and see whether it works.
Right. I think regarding pathogenesis, there is this question from Dr. Chennai, from Dr. Jayanti in Chennai. Does von Willebrand factor have any role in the pathogenesis of ACLF?
I think it's, again, a great question. I think that's we saw increased VWF. We also think that, the coagulopathy that occurs in ACLF is distinct. It's not as well characterized as some of the other syndromes, but we think endothelial dysfunction is a key. We think VWF here may be a marker. It may be a potential therapeutic target. We just don't know it at the moment, but I am completely convinced that endothelial dysfunction, probably consequent on systemic inflammation, is a very important model. And you might have seen some work that we did a few years ago in analbuminemic rats, where we show that giving them albumin improves their survival with improvement of endothelial function. So I think it's very important, but we just don't understand enough yet.
Okay, right. Thank you. This is this question from Dr. Suman Talukdar in Mumbai about how useful do you find the use of gut-selective antibiotics in preventing bacterial translocation, and related to that, whether any thoughts about the use of obeticholic acid for halting inflammation as a FXR agonist.
Okay, so it is the story about rifaximin has already been shown very nicely by many groups that it is useful to prevent the recurrence of hepatic encephalopathy. And whether it's a drug that can prevent the occurrence of ACLF is not known yet. But I think that, if you go back to about 10, 15, 7, 8 years ago, the whole of the TLR4 hypothesis comes from our inquisitiveness to understand why does norfloxacin prevent the occurrence of mortality in decompensated cirrhotics. So norfloxacin, as shown by Professor Moreau recently in a clinical trial in gastroenterology, there's reduction in mortality of patients with decompensated cirrhosis. So it is very clear that modulating translocation is an important model that we have. But the important thing to consider there is, whenever you're using an antibiotic which reduces bacterial diversity in the gut, is likely to have consequent effects in the future. And what I've not talked about today is a product that we're developing. It's called Carbolive, which is essentially an oral adsorbent, which is bimodally porous, and which has also completed its first clinical trial, and hopefully will be entering large clinical trials as we move forward. So just to come back to the question, it is a key target for intervention. But what you're going to use, how long you're going to use it for, how long you can use it for, is it safe, are all the things that need to be sorted. But critical key therapeutic target for the future.
Right. So, continuing with this theme, Dr. Arun from Chennai wanted to know whether there is a role for fungal dysbiosis in ACLF. Should we be looking at culturing and treating fungi in patients with ACLF? Generally, our focus is on bacterial infections in ACLF.
So, there is nice work, as you know, from both from Jazz Bajaj and also from Bernd Schnabel. We're now starting to characterize the fungome and the virome in the gut in cirrhotic patients. And I think that there will be a role. Unfortunately, we have not been able to characterize very carefully. And again, fungal infection is not as common in patients with ACLF as we had initially thought. And in patients that are in the hospital not getting better, I think it is absolutely crucial that you look for fungal infections. And, in patients who are deteriorating, we sometimes even use antifungals without proper fungal cultures. The story here is it's extremely difficult to diagnose what is a contaminant. You get culture positivity in lines and catheters, etc., very easily. And what is invasive? And that story is to be sorted. But I think that, your patient is sick, not getting better, has got high white cell count. You've used 3 antibiotics. I would suggest you could try antifungals at that point. What about the fungome? I think we don't know yet whether we should be culturing the stool for fungi and what it means.
Right. Well, I think your talk has stimulated a lot of questions on the metabolomics. So Dr. Akash Shukla from Mumbai wants to know that is there a difference in the metabolomic signature of ACLF with infection versus ACLF with other precipitants? Because you've played a major emphasis on the role of infections in ACLF.
So it's interesting. Again, you should read the Journal of Hepatology paper carefully. So that was one of the questions that came back to us from our reviewers, and Akash may have been the reviewer, who knows. So he asked the same question. So we categorized patients into infection versus no infection, and the metabolic signature is no different. It's only consequent of the severity of ACLF and its presence.
Okay, right. And Akash has another interesting question that are you aware of any naturally occurring substances that have TLR4 antagonistic activities, like things from Indian and Chinese traditional medicines like curcumin or iberin, berberine, and things like that?
No, I don't. I think that, no, there is I don't know of any. But curcumin, of course, is an anti-inflammatory molecule, but I don't know of any substance. If you find one, please give it to me. It'll be much cheaper to treat these patients going forward, because it's going to be an expensive drug. So we have to find something which is easy to use. But the nice thing about TAC242, now just to sort of come back on that, is off patent, which means that it is generic. It could be generically produced. And I can tell you that, we are, for our studies, going to produce it in India.
Okay.
So there is a pharmaceutical company in India that's producing this drug for us.
TAC242.
TAC242 for, it's going to be called something else, but so I can't tell you where and what and so on, but there is an Indian company that will be producing it for us.
Right. I think Dr. Rakesh from Lucknow wants to know whether drugs which have also got TLR4 antagonistic activities like statins, sartans, and CPG, etc., would they have a role in the management? Because TLR4 agonism has been something that you emphasized.
Yeah, so you might have seen the paper from Professor Bosch and Jordi Sancho Gracia, who published in Gastroenterology, but in a different model. They used patients with GI bleeding, and they randomized patients into simvastatin versus standard of care. And what they showed in that was that the patients treated with statins had a lower mortality. And then they went on to do an animal study where they used statins as a prevention for occurrence of ACLF. And that's what they show. So the major action for statins is not TLR4. It is mainly related to alteration of endothelial function, which was a question before that. So, of course, we don't know. It has many, many, many different actions. I didn't answer the question about obeticholic acid before. I think just to sort of one line there. So we did some studies using obeticholic acid in cirrhotics with looking at portal hypertension. We show that it's a useful drug. But the point is you're limited by dose because there's a dose-dependent toxicity of obeticholic acid. And you might have seen the data from the US where obeticholic acid was administered to patients with severe PBC who had higher mortality. So please be very careful at using this drug without further studies and very careful interventions.
All right. I think we are now out of time. Shalimar, you have a couple of questions that you might have picked out for Dr. Jalan?
Yeah, I'll just take a couple of them. So Professor Sudhanshu Patwari from Ahmedabad and Lata from Hyderabad have asked, is there any role of fecal microbial transplantation, probiotics, and dietary modifications in the management of ACLF?
So there are three parts to that. Let me take the first one is fecal transplantation. I know that there's a lot of work going on in this area, and I think it's an attractive hypothesis. But I think, again, we need to be careful that when you are doing fecal microbial transplantation in an individual that is seriously immunodeficient, whatever we do, we need to very carefully study to see what it does, and then to measure stuff to make sure that we're doing no harm. But we await results. So there are some very different results from different places, kind of stool that you're going to use, what are you going to do with transplantation. It's a very, very, very open question. About probiotics, I don't think that there is any role at the moment in ACLF patients. I don't know whether, so we've just recently published a study with using Yakult, which is Lactobacillus shirota, did nothing. Not one probiotic is the same as a second. But at this point in time, these patients are too sick for you to see an effect with a probiotic intervention. It may be a prevention in the future. And the third one is what? Third one was...
any dietary modifications?
Yeah, so dietary modifications, I think, are going to be very important. And I think that we might see some signatures coming from these metabolomes, which might help us with providing immunonutrition. And the particular things that are of interest, I suspect, is things like arginine, things like supplementation of carnitine, and so on. So this might sort of indicate how we can enhance that side better, because there's serious proteolysis going on. There's serious lipolysis. So there's a lot of work there to do, and I think that nutritional intervention will be important.
Right. A common question asked by Santosh from Vellore, Kamlesh from Surat, G.K. Pati from Vellore, and Dr. Rahul from Jodhpur is, what's your take on plasma exchange for management on acute and chronic liver failure?
So again, these are terrific questions. So you might have heard that we are in Europe and the US, there's a large study due to start. It's called the Apache study, where we're going to randomize 400 patients to receiving plasma exchange or standard of care. So it makes sense. But the problem in a way with plasma exchange is that without replacing immunoglobulins, it does not work. So it's not enough to replace plasma. You've also got to replace immunoglobulins, which is not only extremely expensive, but also not available. So if you're going to treat somebody with plasma exchange for 5 or 10 occasions, you have to think about replacing immunoglobulins. So, as a strategy, it is interesting, and that's a study that we're doing at the moment. But translating into clinical practice may be more difficult than you think.
Rahul from Jodhpur has raised the issue that if ACLF and inflammation plays a major role, could there be any role of routine steroids to suppress immune response in these patients?
So, if you think about it, inflammation and infection are two sides of the same coin in a patient with ACLF. So a lot of our patients are dying from immune failure. And if you think about the slide that I showed you previously, what is clear is that, it is this exhaustion of the immune cells, which is leading to a risk of infection. So I personally think it's going to be a difficult one, which may increase the mortality rather than reduce the mortality of patients with ACLF. Having said that, we are running a trial at the moment, which is out of cliff, which is running for 2 or 3 years, where we are supplementing steroids, not for inflammation, but as a replacement for this altered hypothalamic corticosteroid axis, where we think that the response is not good enough. In patients with ACLF, we're very slow to recruit, but hopefully that study closes in about 12, 18 months' time. That's happening in multiple ICUs across Europe.
Okay, my last question is, Abhinav from Delhi wants to know, when would you consider futility in the context of availability of transplant? Do we have any scores or we have any criteria right now?
Well, thank you for that question. I'm sorry I didn't have the time to touch on it. But as a resource issue, and also for the issue of projecting, the families are not wiped out because we are working in futile environments. We have two papers now. One is out of Cliff, and the second is out of our own labs, own clinical practice, and one in critical care and one in critical care medicine, I think, which shows that a cutoff of 64 on day 5 to 7, day 5 of intensive care, we think that you can probably predict at day 3 and 4, is associated with risk of death of over 90% at 28 days. A score of 70 in our hands is universally associated with risk of death. So we think that, anywhere above a score of 64, we should start to think about on day 3 of full intensive care. We should seriously start to think about futility, start to have those conversations with the family so that they're not paying for patients, particularly in India, being in intensive care for that long. So yeah, it's a great question. And I think that we've started, it's a good conversation to have with the intensivists, because it gives them something to work with when you're having difficult conversations. So if transplantation is not an option, then please think about something else.
Well, I think I must thank you very much, Rajiv, for this outstanding presentation, this very deeply insightful talks, and your exploration of novel mechanisms, which hopefully will lead to more meaningful therapies in the future. We have spent almost 2 decades characterizing a very severe illness and trying to understand it without coming up with too many novel solutions. So the question that how has identifying ACLF as a separate entity impacted on the outcome of chronic liver disease? Have we made a difference? Is it worthwhile all this academic churning that's been going on? Probably the answers are likely to emerge to these questions in the next 5 to 8 years as these insights evolve into effective therapeutic modalities and we learn to use them better. So thank you very much for these insights. And there are over 100 questions, of which you answered about 30 odd. So you'll probably find the balance about 70, 75 questions in your inbox. And could you please spare the time from your extremely busy schedule to address these answers, because your audience will be very interested in your responses. And we'll post them on the ISG website for their reference. Thank you very much, Shalimar, for taking in all these questions and asking all these insightful points. And also, we are missing Govind on this panel, but you've made up for that quite well. Yogita and Dinesh, thank you very much for your coordination. And I'd like to thank Dr. Reddy's lab, who has helped with the putting together and transmission of this masterclass. Well, I think with this, we come to the end of this session. Next week, next Sunday, we'll have a talk on back to more mundane GI-related topics. And Professor Amit Datta from CMC Vellore will be talking to us about some common GI symptoms, including things like hiccups and belching and proctalgia, fugax, which we appear very peripheral and insignificant to many clinicians, but are of great concern to patients who are afflicted with these symptoms. And we look forward to hearing from him next weekend. So with this, I'd like to thank all the participants, and particularly once again, Professor Jalan, Dr. Shalimar, and the rest of the team for this session. Thank you very much.
Thank you, guys. Thank you, everybody.
Bye-bye.
Bye.